Good evening, everybody. This is Dr. Verdiales from the Atlanta office. Always on Tuesday evenings, I like to share some ideas with you, and I love to hear from you because sharing is caring, and that's how we can all improve this fertility journey. So I usually will pick a subject or discuss a few cases that I've seen in the last few days or week that could impact somebody else watching this video either now or later. So tonight I didn't pick up an exact subject. I know that a lot of times we run out of time with questions. So I want to have a different approach and be more of a question answer format for the evening. So if you have a few questions that you have not been able to find anywhere else, let's go and hit me. All right, so I got one here. When is it common to get a positive test after a 3-day transfer? So from the day of the transfer, you might get a positive test about 10 days after. So that's where, I would do it. Hi, everybody again. So I know that one of the challenges, this is not a medical challenge, but I know that one of the challenges that you guys have been having is getting through to us, okay? And I was today kind of troubleshooting that. I spoke to the head of the call center, and we're going to try to work on getting more staffing. We're really busy, and I want you to feel comfortable reaching out. I'm going to give you a few emails and phone numbers to kind of facilitate the process of getting you in. So some of the Atlanta staff, this is Jenny at cnyfertility.com. She is the one of the financial advisors and one of my right hands. Then there's El Catano at cnyfertility.com. So Lisette is the office manager, and she is also a way to get in to see me or see us in general. The Atlanta number is 770-266-0933. And I also have a Facebook page for the patients. My name, Maribel Verdiales, MD. And that way you can also send me a quick message through Messenger, and I will forward to the front desk to get in touch with you. Okay. I know that it's been a very big challenge for some of the ladies. I've had multiple complaints about that, and I wanted to bring that up. All right, so let's keep looking at some of the questions for today. All right, so we have a happy ending. Miss Elaine, congratulations. May you and your family be very blessed. I love happy endings. I love getting people pregnant. And it's funny, I can say that as a female. Although, you could argue that males like getting people pregnant too. But I do enjoy this journey, walking it with you. So Isabel is 8 weeks pregnant. Congratulations. And your progesterone has been fluctuating 12, 26, 31, 24. That is normal. Our hormones always fluctuate. Okay. In general, if it stays above 10, you're good to go. How well does ACG wash work with a fresh day 3 embryo? It works well. It kind of primes the lining to receive that embryo. The way I like to see day 3 embryos is kind of a near-term baby. So when you have a slightly premature baby, it does well, it adapts, okay? It might not be fully cooked, but it will adapt to the environment very quickly and do as great as a full-term baby. So that's kind of how I see day 3 babies. it's almost like having a little preemie put in. They do very well, and most of them adapt just as great as a blast. Okay, so they will have ACG receptors in them, and it just kind of helps that lining getting primed to receive the embryo. So it works just fine. The birth control over suppress, low AMH patient, 1.78 AMH. So I know that a lot of fertility clinics out there will use a lot of birth control pills to, kind of program the cycles better, or do batching, meaning group a whole bunch of patients and start them together. We try to avoid using birth control pills in general, especially on low reserve patients. One exception that comes to mind would be a PCOS patient, because suppressing them actually could help. But somebody older or low AMH, we do try to avoid it. There are occasions that is almost unavoidable, especially if we're not able to get a true baseline, then we'll try to do that. But most of the times we will start with estrogen, progesterone, instead of the birth control, to try to suppress the ovaries a little bit and get a true baseline to start. Can I take Omnitrobe at the same time as Gono F and Menopur? Yes, actually, a lot of times I recommend that regardless. The human growth hormone or Omnitrobe helps sometimes during the stim. We do sometimes prime, ahead of the stimulation cycle. So even 1 to 3 months before of Omnitrobe, especially on the lower reserve patients, could be life-changing. And I've also seen that even if you just use it during the stim, it could give you a push to have better quality eggs. And better quality eggs means better quality embryos, or more surviving eggs overall. Also, will you be opening any other facilities in the near future? Northwest Florida would be a great spot. Well, I was actually talking to Dr. Kills earlier, and there is plans to expand into the Florida market. It's still very, very early stages, so I can't really give you a time frame for that. We are expanding the Atlanta office, crossing our fingers, toes, and a lot of prayer for this summer for IVF. Probably transfers will happen before IVF, full capacity happens, but we are working on it. Okay. I've been taking estrus and prednisone and feeling really jittery in actions. That the prednisone will do that for you. What can I take to reduce symptoms? I'm allergic to Benadryl. The prednisone is the one that makes you jittery. Maybe we can decrease the dose that you're on and look at the dose S-trace. It does not make you jittery. It makes you irritable and emotional and breast tenderness. So we could look at the prednisone dose you're on and maybe decrease it, or if possible, don't even take it and look for alternatives. I have been trying to book a consultation and heard back. Yes, I know, Mandy. And that's the reason that I'm giving other coordinates. The call center is super, super overwhelmed. I was speaking today with the head of the call center, and they are backed up to December, answering emails and voice messages. Every consultation takes a while because they have to set you up on the system, get your portal going and all of that stuff. And they are short-staffed. So we are working to fix that and expand the call center so we can, get it going. So in the meantime, you can call directly to the Atlanta office, 770-266-0933, or you can send an email to either lady, jpettis@cnyfertility.com, or you can send me a message through Messenger. Can you discuss a natural cycle and how that works? It depends on what you mean with a natural cycle. Are you meaning a natural cycle for an FET, or a natural cycle for just trying to get pregnant? Okay. All right. Yes, yes, very good. Thank you for all of your happiness. I love you all. Yes, another happy mama. Many blessings to Yvonne and her family. Can you do an ACG wash and an embryo glue on a first transfer? Yes, you can. Baby glue now is standard for all of our transfers. Personally, and this is just me, I like to space them out. So if you're going to do baby glue before the transfer, then ACG wash the day before. If you want to do a Neupogen wash or a PRP, then do it the day before that. So I don't like putting a lot of stuff in the uterus at the same time because we really don't know the interaction between the things. So I like to put like one in and let the uterus sit and kind of preparing it in layers. That's my opinion. Low ACG, but estradiol is 1923 and progesterone is 30. What's going on? It depends on the scenario. It could be an early pregnancy. It could be a biochemical. Obviously, with a very high estradiol, if if you had a retrieval, it does make sense depending on how many eggs they took out. And progesterone at 30 is normal. After a miscarriage and a chemical, is ERA recommended or only if no implantation? So I think that I would not do an ERA, but I would look into why are you miscarrying, and that will include, is there any genetic disorder? So genetic testing for you and your spouse, including karyotype. Checking if there's any issues in the uterus. So I would repeat the saline. Are we dealing with chronic inflammation/infection? So I would do an endo scratch, PRP, and antibiotics, triple antibiotics. Is there anything in the pelvis? How about laparoscopy, hysteroscopy? Kind of looking, coagulation disorders, nutritional deficiencies. So I would kind of stop, really assess what's happening, empirically, at least do an endo scratch, PRP, and antibiotics, get you on a very robust supplement program, and yes, and check genetic testing and coagulation disorders at the very least. But ERA, if you're getting pregnant, it's not really going to add a lot, I think. What are the chances of success with IVF when the issue is anti-sperm antibodies in men? It's higher, definitely higher. And especially with our immune protocols, we will be able to really tone down your immune system. So pregnancy after uterine ablation. A pregnancy after uterine ablation is going to depend if there's any lining left, and if you're having at least some spotting in a cyclic manner. Sarah, I would encourage you to message me personally. I have a few techniques to help with that, but we do need some endometrial lining in the uterus to be successful, and we can definitely check on it. Okay, you need to have some lining, and then we can try to work on it spreading like you would spread grass. But if they were successful about killing all of the endometrium, it's going to be near to impossible. If there's any residual endometrium, you're going to have at least spotting. And then we can do uterine priming, PRP, kind of scratch the uterus to spread it around. What would cause estrogen to fall from 83 to 60C on day 1 of transfer? That's normal. I mean, you're going to have fluctuations in your hormone panels. Okay. How do you get tested to see if you have endometriosis? There's several things. There's a new test that's by blood. Oh, what's the name of the test? I forgot. But that's just going to tell you if you're at higher risk or lower risk. Eretiva, something with a eva ending. And then the gold standard is laparoscopy with biopsy. So embryo glue is I think it's a glycoprotein, and essentially it has been shown to increase adhesion of the uterus to the embryo to the uterus, so therefore increasing implantation rates. And CNY uses it standard, okay? It is included in the package these days. Is there still a chance of being older at 39 and higher BMI? Absolutely. Age is just a number. We would have to see your overall health and how are your ovaries doing, okay? If you're planning to use your own eggs, because of course, once we get into donor eggs, then age is really irrelevant. Yes, so if you have any questions, particularly Ileana, if you want to talk to me, send me a message through Messenger, Mary Belverdiales, MD, and I will get to you tomorrow. Hello, de Puerto Rico. Tomorrow we have a Spanish Facebook Live. No, actually, I'm switching that around. I'm doing Sundays Facebook Live in Spanish starting this Sunday. AMH of 0.01, FSH of 50. What did you recommend? So when we're dealing with such a low AMH, so less than 0.1 and an FSH of 50, we would recommend donor eggs. Repeated miscarriages, can low motility or quality of sperm cause it? It can, because if there's an abnormality in the sperm, there might be an abnormality in the DNA that the sperm is carrying. So I would encourage you to do genetic testing on your husband, including karyotype. And there are things that we can do to improve the quality of the sperm. Everybody knows about Clomid, but Clomid only increases the number, not on all the men, but that's kind of what it does. So not the quality. Then you can go into certain supplements. CoQ10 increases motility. Glandular therapy improves the morphology, including minerals, will improve overall health of the sperm. So 22-year-old with an AMH of 1.4, it's actually considered low. An AMH of 1.4 for a 22-year-old is low. So we have to see what is happening with your eggs. And so I would recommend a full evaluation, health-wise, any inflammation markers like CRP, like erythrocyte sedimentation rate, any autoimmunity that it's getting missed. How is your thyroid? Are we dealing with subclinical diabetes or insulin resistance? There's something else that's happening that needs to be addressed. And having a missed one failed IUI, that's not that significant. I mean, IUI is just super sex. Just by concentrating and giving the sperm a head start, you increase the chance of success by about 10%, but it's still super sex. So you have to try multiple times, just like you're having sex in the bedroom. Okay. So to fail transfers, should I do a couple of months of priming? Yes, I recommend priming 1 to 3 months. And acupuncture, awesome, bringing some flow in there. So you had a laparoscopy, that's great, because then hopefully they clean things up. And like I was saying about priming the uterus, I would try to work on decreased inflammation. So keto diet, there's certain herbs that you can use to decrease inflammation. CBD oil, it's another way of decreasing inflammation. We can combine natural remedies together with Orlisa. I like Orlisa quite a bit, to try to get you ready to have a more successful cycle. Enzyme therapy, okay? People with endometriosis, adenomyosis, any potential adhesions, enzyme therapy, even though enzyme therapy, so there's serapeptase, the bromelain, the nattokinase, those tend to work longer. But if we're trying to just get it a little cleaner for successful IVF, I think it's worth adding. Some people do not tolerate enzyme therapy. I had a patient and she tried so hard, but it was really messing with her stomach. But most people will tolerate it. The dose might depend on tolerance. You can have a laparoscopy done where they go in. Okay. Can vaginal progesterone cause nausea? It can. Usually the culprit of the nausea is the high levels of estrogen, and that happens in pregnancy as well. Is the rise in estrogen that will cause the problem. Can somebody request for twins while doing IVF? Yes, it is not recommended. You know, it's not kind of like McDonald's, get the biggie. Two, more is not better. People forget that when you're putting 2 embryos in, it is an artificial twin pregnancy, okay? And even on a spontaneous twin pregnancy in nature, we're dealing with a high-risk pregnancy, higher risk of miscarriage. Yesterday, we had a lady, she had requested 2 embryos, they both implanted, and she lost them at 6 weeks of pregnancy. Okay, increases chance of miscarriage, increases chance of preterm labor. So imagine you're working this hard, you end up having your babies at 26 weeks, and that puts them at risk for developmental disabilities or physical disabilities. So we have to think about those things when we're requesting twins. And like one of the other doctors said, we have never had in the 20 years of CNY had a couple request twins and having them successfully and then come back for a second twin. Twin pregnancies are complicated, higher risk of miscarriage, preterm labor, gestational diabetes, preeclampsia, and then you know, I am a mom, so I know what it's like to have a newborn, and I cannot possibly imagine how much harder would it be to have 2 newborns at the same time. It's 49 a good HCG for 4 weeks of pregnancy? Yes, very, very adequate. Okay. I will be doing my monitoring in Atlanta. All of our CNY offices open at 7:30, so you can definitely request a 7:30. And then Miss Amy is talking about a natural cycle for FET. There's 2 versions of the natural cycle. So you can have a true natural cycle, and meaning no ovulation induction of any kind. I personally like to trigger. You can do a natural cycle and just observe until you see the corpus luteum, but I don't like that. I think you can miss the window, and for progesterone preparation for transfer, you really want to control it to the hour. So you can do a natural cycle as soon as we see a large follicle, we trigger, provoke ovulation, and 36 hours later start progesterone. You can also do a ovulatory cycle, kind of a natural cycle. You can do letrozole, meaning provoke ovulation, trigger, and then do the appropriate days of progesterone before transfer, meaning day 3 embryos will be 3 days of progesterone, blast is 5 days of progesterone. Okay, very good. Thoughts on Valtrex, Intralipids, Neupogen for recurrent implantation failure. I really like Intralipids, yes. Valtrex, yes. But I do like steering the pot, the uterus is a capsule, so it's kind of hard to penetrate with antibiotics. So I like to kind of clean it, steer it, get some of that blood flow going, do PRP, which is bacteriostatic as well. So it's going to help with healing and also prevent infection, and then hit you with triple antibiotics to cover parasites, yeast, and different types of bacteria, okay, and anaerobes. And the Atlanta office or the Monroe office will have, well, we're hoping to have IVF by the summer. Even though I had a hysterectomy, can I still donate my eggs? It depends on your age. We take donors until 32 years of age. Okay. So I have done 3 rounds of Clomid and 2 being IUI, no success. I have my left tube with endo remove. So no, I think that the biggest thing would be to get labs. If you can have your labs ahead of time, and that includes your, like the most important ones ahead of time would be your AMH, your FSH, day 3 labs, TSH, thyroid, prolactin level, vitamin D, and then, semen analysis and, your uterine evaluation. That gives me a lot of information to at least give you a preliminary plan, okay? What to do post-transfer? First and foremost, pray, be positive. And then you are on Lovenox, ACG booster, and injections. That's pretty much it. It is with pregnancy in general. It is the waiting time, so you can get ready for it, and then you kind of have to wait and be happy. Okay. AMH of 6, do you automatically say PCOS? Absolutely not. Type 1 diabetic on insulin pump and metformin to fail IUI so far. On my diabetics, whether they're type 1 or 2, I do like to see that hemoglobin A1C under 7. And if it's less than 6, even better. So very, very well controlled. On a diabetic, because of the variations of sugars, I would very much work on gut flora, meaning getting very good probiotics in and antibiotics even before starting, because they have more fluctuations of sugar, so you're more prone to have subclinical infections, especially in the lower genital tract. Okay. CBD oil, we do have some at the Atlanta office. So is an embryo 2BC on day 5, is it good? It's okay. It's an okay embryo. Now, take into consideration that even though we try to grade the embryos, you can have an embryo that's 2BC that makes a baby, and then an embryo that's an AA that doesn't work. Okay, same thing as I have seen PGT normal embryos that don't work, and then that one day 2 embryo that it's a leap of faith create a baby. So this is all guidance to try to help the process, but remember, the last word comes from the divine. Okay, so Miss Megan, you have adenomyosis. We should work on that. That is a sign of inflammation. And I have a few protocols for endometriosis and adenomyosis, supporting the immune system. That way, indirectly, we clear some of that the enzyme therapy for you would be really good, and we could do that with the Orlisa. I would put you probably on Orlisa, potentially laparoscopy, hysteroscopy, endoscratch, PRP, antibiotics, enzyme therapy, glandular therapy. So it's pretty robust. So just text me, and we can get, if you're already a patient, just get you in as a follow-up, or just get you in so we can discuss further. Alrighty, so I'm going to answer, I think this is very good. I know there's a lot of talk about the COVID vaccine, and I'm going to tell you, we came together as a group, and there's not enough data on the COVID vaccine and pregnancy, so we are encouraging our patients that if they want to get vaccinated, that they wait 4 weeks before they do their IVF treatment. Of course, some of you will be in the middle of the treatment and get the vaccine. That's how medicines and vaccinations start getting data on early pregnancy and stuff like that. But if you know ahead of time that that's what you want to do, we encourage you to avoid it for multiple reasons. One, there's not enough data on the vaccine. Two, a lot of the medications that we use will depress your immune reaction. And if you're going to have the vaccine, might as well have the full benefit. Full benefit takes about 2 weeks to kick in. Okay, so if you're going to take the risk, might as well get the benefit of getting the antibodies. All right. Okay, well, time's up for tonight. Always a pleasure to be with you. You know, positive thinking is number one. Keep your eyes on the goal. This is, like I always say, it's a marathon. It's not a sprint race. And as long as there is life, there is hope. So may you all be blessed. I will see the Spanish crowd on Sunday, probably about 7, 8. So Sunday nights will be Spanish from now on, and then Tuesday evenings will be in English. May you all be blessed again and have a great rest of your week.